Just wanted to say hello to everybody. This is part two of the neuroimaging basics, which we started last year. It's always a pleasure to be talking with other departments, particularly neurology department. Um, I believe there must be residents from neurology or sometimes even neurosurgery and rehab here. If you guys have any questions, please feel free to, you know, just talk because you can see my screen. If you guys write in the chat, I'm unable to see it. So basically, I'm sitting and talking to my screen. That's how I feel. So if you guys want anything at any time, because there are a bunch of cases and it's very practical oriented. I like an interactive session because I want to address your need rather than just going on and on about what I have to share. So if you guys want to talk, please just unpause, wait for me to finish my sentence, and just button. I'm going to pretend we are still in our conference room facing each other, only more comfortably. So I'm going to really start. For those interested, the CME code is 1280668. So go ahead and note it down. I would even put it again when towards the end of the session, and it should be on your chat also. So welcome back. It's time to get a little dip into the ocean. The learning objectives of this course, it's to identify various sequences in MRI. I know there is a population here who's really intelligent and they pick things, and sometimes they even give us a call and say, hey, what do you think about this? Given their vast experience over a decade or more. But then there are also younger learners among us, and this is to just refresh everybody. The other objectives are to describe and analyze findings in MRI and CT, to evaluate and order the appropriate study for what you want. I think that is the key, my main objective for this. Overall outcome is to have better clarity in basics of neuroimaging. And also, I believe in metacognition, which is to know what you know and to know what you do not know is the very beginning of you to even start learning. So as we go through this, there'll be areas that you think you know, but then when we start talking about it, you'll find out that, there's a loophole here or there. So something for you to ask here or something for you to even look up. I'm one of the neuroradiology attendings within the department, so you can always contact me if you do hit a wall and I can help you with it. We're going to do a quick review, okay? It's going to be a low stakes, so everybody is going to join and take a look at this. There's going to be a poll. Let's see if it works. If it doesn't, we can always talk about it, but take a few seconds to look at this image. Inpatient, next slide. Need extra time, interrupt me. If not, I'm just going to move on. These are like ant mini cases. This is the poll. It's poll everywhere. If you can go online or if you can text, that'll be great. I realized that last time I was just calling upon residents to talk. Part of the art of being a resident and a physician is to be able to speak up one's mind without fear, and also to learn. There are no right or wrong answers when you are as a resident in a teaching environment. But this I thought would be more easy for people to participate.
Dr. Ram, can you share the address again of where to poll?
So it's at the top. See, polleverywhere.com. Can you see it at the top of my screen?
No, it doesn't show up.
Oh, okay. Let me go back. It's supposed to be poll everywhere. Poll, Poll, capital EV dot com/. Chithra RAM, which is CHITHRARAM 393. I'm going to try to go back. Nice. Dense vessel, sign, large. It's so funny. I'm trying to experiment with this and it's going all over the place. Territory, vessel concerning infarction, cool, MCA. I think you guys pretty much covered it. Ischemic, it's in a territory of a vessel.
The results are not showing up on our screen.
Oh, it is not. I can see all that popping up. It's in my screen share. I am not sure how you guys can see it, but I am able to see it's the next slide. Can you even see describe the findings ... for the question?
Yes, that's a blank screen that's showing up.
Oh, I cannot. I have no idea how to make it visualize. I don't want to stop sharing, but I'm going to.
Yeah,
Oh,
yeah,
okay.
Dr. I think
What's
this
your
is Chris
response?
Barton. I think what's happening is because it doesn't include the link and stuff above, I think
Uh-huh.
for some reason it's not linking with the internet for some reason with the poll everywhere. So it may be a little bit more complicated of a solution, but I think if you read what people are saying, I think that'll be okay.
Great. So I tried to activate and show the response, but that's what I was seeing. I think people got it. So I can see the dense MCA sign, ischemia, infarction. Those were the words that were popping up. Do you guys see this screen?
Yes.
Yes.
So now that we saw it, I think the age-old way of interaction, just talking, seems to work better. So at any point, please feel free to talk to me because I think we will get more out of this session by talking. Can you guys see this slide? It says rank the studies you will order from greater to lesser importance.
Yes.
Can you see number 1, MRI brain, number 2, MRA brain and neck, number 3, CTA head and neck, and then 4 is digital subtraction angiography, and 5 is CT perfusion. Can you guys see those options?
Yes.
Good. So anyone wants to speak, or you can poll and I can say what I see in the poll. Because you guys are already there.
Hey, Dr. Ron, this is Tyler Ball with neurosurgery.
Uh-huh.
Yeah, I think I'd start with CTA head and neck. I mean, you want to do things that are time sensitive first. Make sure you can't do an intervention that would, like a thrombectomy or something. There's already hypodensity on the CT, so it may be past the point of that. But I think a CTA head and neck is probably the quickest thing to get an answer.
Nice, Tyler. So can you tell me, can you rank the rest? Because you gave
Yeah,
me a reason. Every one of this has a reason, and you gave me a good reason for CTA head and neck.
so
How do you rank the rest?
I would do CTA head and neck first, and then with it, I would do a CT perfusion with it to what's infarct and what's penumbra. Then I would do an MRI brain after that. The MRA brain and neck, I don't think would be necessary if you've already done the CTA head and neck. Same thing with digital subtraction angiography. I don't know that that's necessary if you've already, if you've done the rest of these. If you've done an MRI of the head and a CTA of the head and neck, unless you see something like, that suggests vasculopathy or something like that, I'm not sure the DSA is necessary. So I would say 3 would be my first, or
Uh-huh.
3 and 5 together, and then
Mm-hmm.
1, and then 2 and 4, potentially not necessary, maybe for if it looks like vasculopathy or something like that.
So when I said digital subtraction angiography, you're thinking in terms of diagnosis, right? But
Right,
what
right.
else can it do?
So if there is a clot and the perfusion is favorable, then you could do a DSA and a possible thrombectomy.
Right. So I completely agree because the flow of thought that generally residents would do when they get is they would get this whole package. Sometimes you're trying to fight with time, right? Every minute gained is every piece of tissue saved. So I would go with 3 CTA head and neck because I already know there's a thrombus. Now I'm trying to get a roadmap for the interventionalist to go and do something about it. And the MRI brain, when I'm having issues, that's when I do. People always think that we need MRI brains, but this was a slam dunk case. It has to be only that. Now, it's a large area. It definitely can rebleed or bleed because when you try to open up a huge thrombus, then there is you have side effects and everything. But I don't think we have a choice with such a big thrombus. So you'll have to rush soon to get to thrombectomy. CT perfusion. If the CT perfusion says that you have a large infarct and you have a big thrombus, then what do you guys do as a clinician?
If there's a big thrombus and there's a
This
large
patient had a big one, right, Tyler? It did have a large, nice, hyperdense MCA sign.
yeah, it did. The only thing so on the CT you could already see a good bit of hypodensity. So, if the infarct is already large, like if the core infarct is almost as large as the penumbra, then it may not be worth trying a thrombectomy or it may be dangerous. But if there's a large penumbra and a small core infarct, then the patient could go straight to a DSA or straight to the get an angio and possible thrombectomy. So if that were the case, I would just skip the MRI brain.
Cool. Anybody disagrees with Tyler? I want to just share with you guys what I got in the poll, okay? They said CTA head and neck was the first in the ranking. Kudos to you guys. And you know what came second? MRA brain and neck. Personally, as a radiologist, if someone comes to me and says, do you want a CTA or an MRA? My first choice is MRA is easy to read. It's like a quick look. But when I look at my CTA, I can see all my vessels and everything. It's the closest I see to a DSA image. So if I'm already having a CTA, which is of good quality, I don't understand why I need to even get an MRA. What other information am I expecting really to see, right? But it's one of those things that we keep seeing. If anyone has any reason why you guys do it, I think we can always talk about it. You can feel free to interrupt. But personally, for me, I think the roadmap is great with the CTA. Then I don't understand why we need to get an MRA and waste time because getting into the MR scanner and getting out takes a lot of time. We are talking over 30, 40 minutes locked up time there, right there, just for the MRA brain and neck. And then if you give contrast for the MRA neck, because in the carotid bulbs, usually you have this face encoding artifact, we can throw it out. But then if you want to measure the stenosis there, it gets even more complicated and longer. MRI brain, sure, but at this point, I'm not sure for this particular patient. So though we think the same thing all the time, and all these answers are correct, when you want to rank and you really want to jump at it, particularly when you see a really good CT head, then there is a lot we can cut down on. Tyler,
Yes.
good job, Tyler. You're
Oh,
ready to be, you know what, you can come and be part-time radiologist.
no, no, I'm definitely not ready for that. But I did have a quick question after the one time that we use MRA, rather than
Yes.
CTA, it's
Uh-huh.
issues like in trauma. If we have somebody that we've got a suspicion for spinal cord injury, and they also have some fractures like transverse foramen fracture or like a fracture dislocation, and we're worried about a vert injury. Since they're
Uh-huh.
already getting an MRI of the C-spine, we'll add on an MRA of the neck to look at the verts. Is that useful for you guys? Like, is it sometimes we can interpret them, but sometimes they're hard to interpret, and we end up getting a CTA anyway. So, do you think it's worthwhile if they're already getting an MRI of the C-spine to try to start with an MRA of the neck, or would you pretty much always just suggest a CTA on those patients?
Okay, so this is a very targeted question that we have, right? There's a fracture in a particular place. That area you're trying to find the vertebral artery. Of course, you can have associated whiplash in other areas where you can have dissection and stuff. So just because you're there on an MRI cervical spine itself, I can see bits and pieces of flow voids as I go in and out, but not all of it. When you get an MRI neck, like I said, if the patient can hold still with that trauma, it does take longer. If you can get it, great. But if you don't have the answer, because I can see a few things. One, I can see a narrowed vessel easily on an MRI neck, which
Right.
means I'm thinking in this setting is dissection. Can I see an intimal flap? Probably not. I need contrast. But on my CTA neck, I can really see a nice, good intimal flap. Okay? Small dissection, small pseudoaneurysms, so much easily seen on a CTA neck. My question to you would be, okay, Avaya, getting an MRI neck, if I don't see anything obvious meaning on a CTA neck, I can pick 2-3 millimeter stuff. On an MRI neck, usually I can, but if I cannot and I say I don't see anything, are you comfortable moving on? That's the question, right?
Right.
If 100% you want to know, then that's one thing. But however, if you're not going to be anticoagulating the patient because you need to take the patient to surgery to fix something, does it even matter?
Yeah.
Anyway, you're not going to fix this, right? You're going to do your surgery, you're going to do all this stuff, and then you're going to start treating this as the second step. You have enough time to get your CTA neck. So when I look at it as a radiologist, I would give an answer different from when I look at it as a clinician, because I'm buying time, I'm trying to find, and then once I'm done with my surgery, then of course there's post-op bleeding can happen if I start anticoagulating. So I'm waiting for the period of time after that when the patient is stable. Now I do have time to look into all this. So doing another study at that time is not going to change hugely the management that I'm planning on the patient. But instead of rushing to surgery, am I going to be looking at this? It's an option if it's going to change your management. But on an MRI neck, can I see dissection? Yes. A long, thin string sign is a good sign no matter which modality I'm using. But intimal flap is hard. There's one more thing. Can anyone tell me how, when you have a dissection, you can always have sometimes even complete occlusion of a vessel, right, in the scenario. So if you want to pick it, is there a way you can tell the difference between a vessel that is completely occluded versus something else that's happening there that I cannot see on an MRA? Because if there is no flow seen in that side of the wart, say right vertebral artery is injured or whatever, I cannot see the right wart. How do I interpret it if I don't see a right wart on an MRA neck without contrast? Is it occluded? Is it dissected? Is there a subclavian stele? That will be an issue. CTA also will not help with that because all it will show is there flow, is it not, doesn't it have flow, it will finish off. But if there is flow in a condition of subclavian stele, MRA neck with and without contrast is the gold standard because it is related to the direction of flow. So when you have an MRA neck without contrast, it will have no flow. But when you get it with contrast, you will have flow because of the direction in which we are coding and because of the contrast. So in that one instance, MRA neck helps. But I do see we are digressing from what we are going to look at. But did it answer your question though, Tyler?
Yeah, that helps. I mean, it's something where you can't really rule it out with the MRA neck is the bottom line. Like you'll see it if it's something obvious, but you can't really rule out a dissection with MRA neck. Is that what I'm hearing?
Yes. So a CTA is the standard if you have time. But if it's not going to change management, why do it at that time? And if you're worried about subclavian stele or a long dissection or occlusion, then yeah, that's an instance where MRA head and neck with and without contrast would help. Okay. So this finding, does someone want to come? I did poll it, but we might skip a poll just to save time. Anyone else want to jump in on this one? It's the same patient, my very first patient. We're just going in you guys suggested CTA head and neck, and that's what we did. So you can see that there is very little to no flow in the right supraclinoid very distal aspect. And then on the right side, pretty much no flow in the right M1 segment. There is a little bit of collateral flow in the right NCA Sylvian branch. There's also some irregularity noted at the origin of the A1 segment of the right ACA. So we know about the hyperdense NCA sign, but when you look at the CTA head, you also see that there are changes in the supraclinoid ICA and in the right A1 segment. I'm not going to pull this, but what was the modality we just looked at?
I look like a CTA.
CTA. So I just want to understand, how do you tell a difference between a CTA and an MRA based on an image?
Kind of look at density, then also just soft tissue definition.
Density, soft tissue. So if I was a first-year medical student, what density would you suggest that I look at as a resident? How can you help me? Because to me, everything looks the same, right? Believe me, when I was a medical student, everything looked the same to me.
Mm-hmm. And you like a quantitative measure, I believe, is Hounsfield units.
Okay. Instead of going very complicated, the first thing I would say is look at the skull. This is for everybody. CT and MR, if they don't give you any clue and you just have a picture on your screen, how do I look at it? The skull looks so bright on your CT, but when you look at your MR, it does not look like this. So off the bat, you would know it's something related to CT. And of course, you can see the vessels, so it's some sort of an angiography. Great. And who was that?
My name is Nick Dietz, neurosurgery intern.
Great. Hi, Nick.
Hi. Thank you, Dr. M.
At any given time, if you guys don't want to say your name, that's fine. It's just that I want to appreciate you guys
No.
because it's a bigger crowd, so
absolutely.
I don't mean to put you guys in the spot.
That's okay. Thank you.
So right MCI occlusion, everybody gets, but as a radiologist, I want to be useful to you guys. So that's when I come in and I say about all this right A1 origin, right ICA terminus, but then you guys can see it if you want to see it. So some of these cases I was just going to go through because I wanted to show you guys a bunch of cases, okay? This picture, when you see bright, whatever spread in between brain, it's going to be hyperdense. So density for CT, we use the word density. For MR, we use the word intensity. So in CT, when it's hyperdense, hypodense, or isodense. So I see hyperdense material in the region of the cisterns. I see in the prepontine cistern, in the basal cisterns, along the course of the MCA, in the sulci. So definitely it has to be subarachnoid space. So this is subarachnoid hemorrhage. I go back, and my best friend is my old image. But before I go back, I'm seeing that there is diffuse lack of CSF elsewhere in the sulci, right? There is diffuse cerebral edema. So I do see the right temporal horn asymmetrically larger when compared to the left temporal horn. And I'm thinking maybe that temporal horn is trapped. But the fourth one now, because it's very hard to see the sulci, so I can't tell if it's 70-year-old or it's a 30-year-old unless I see the history. So fourth ventricle, I'm kind of wary, but the basal cisterns are all occluded, so they can cause any kind of obstruction anywhere along the course of the CSF. So retrospectively, when I go into a CT head, I see this very nice isodense round to oval structure in the intrapeduncular cistern. So first thing for any time the radiologist looks at is what is normal, what is abnormal. If I'm seeing something abnormal, then I have to describe it. When I describe it, usually the differential comes into my head. Okay, isodense round, what can it be? Certain kinds of tumors and lesions, right? And then I'm thinking, what can be there in the intrapeduncular cistern? It does not look like it's really arising from the midbrain going into the cistern, but it's in the cistern. So it should be another structure. And with the subarachnoid hemorrhage, I know it's going to be some kind of an aneurysm. The best one would be basilar tip. With this in mind, the next thing I'm going to be doing is ETA. So it's the human head. You know, the basilar artery usually looks like this body flailing with the hands without a head. The aneurysm is like the head of this vessel. So at the top you can see a large, it's a giant aneurysm, which is more than a centimeter. And then below it you see the digital subtraction angiography, where the first image on the left is mixing of contrast with blood within the aneurysm. And the next one, they went and put in the coils. So they did a fantastic job in that when they put in coils, they can extend back into the basilar artery or they can go into the posterior cerebral arteries. Either way, they can compromise the flow in the PCA, leading to PCA infarcts in these cases. However, here I can see that there is flow in both the PCA. But to a good eye, we need to pick on the right image at the bottom. You can see a little bit of contrast within the coiled aneurysm. So now I know it's not fully coiled. I just need to continue to follow it up. It can grow bigger. But if I try to put in more coils, then I can cause compromise of flow in the PCA. It's a fine call that the interventionist has to make at that time. I think they did a great job, and it's a large one. So if you start packing too much, you can even rupture things. That was a basilar tip aneurysm. This is for my beginners. So I just keep putting anatomy slides along with it, but today I won't be able to run it. I wanted to give an anatomy quick correlate to the next study. But I guess you guys know all this 3-vessel aortic arch. The very first vessel that comes is a brachiocephalic artery that splits into the right subclavian and the right common, which gives the internal and the external carotid arteries. The subclavians give the vertebral arteries. So basically in the CTA neck, I'm checking the carotids and the vertebral arteries. The question that I have for you guys is, how do you tell the difference between an ICA and an ECA? There's one image. How do you tell the difference?
The ICA is not going to have any branches in the neck, Dr. Ram.
Perfect, right? Quickly, that's a quick thing. So if I don't see branches, I'm thinking ICA. Now, which is a vessel that is almost running parallel to the internal carotid artery, but is a branch of the external carotid artery? It goes along the pharynx and it ascends. So it's called the
Ascending pharyngeal.
Perfect. So the reason I'm even asking that question is because sometimes when I'm looking at my CTA, it makes a huge difference if a vessel is occluded, which means it's gone, versus even if there's 1 to 2% flow in it, because there is hope. So then they would intervene. Now, if you start seeing this ascending pharyngeal, like right, ICA is completely occluded and you have some flow in the ascending pharyngeal, be careful not to misinterpret. That is the reason. So this one, it's a CTA, and the last image is last image meaning the rightmost image is a surface rendered image of just the carotid vessels. What I'm seeing is a narrowing, the arrow, just a regular arrow, shows a narrowing of the internal carotid artery bulb. And there are some plaques in and around this region. And then there's a little outpouching that comes from this area of narrowing from its origin into the region of the bulb with the plaque. So the question would be, am I looking at an ICA severe stenosis with a plaque with an ulcer through which contrast is going into the plaque, or is it going to be like a pseudo aneurysm with a dissection in it? Will I be able to tell the difference? This is a hard question, right? But a lot of times in the bulb, statistically, it's a great location for plaques. And the outpouching really didn't go all the way further from the vessel. It's kind of within the expected limits of a bulb. So my guess would be to call it an ulcerated plaque. Ulcerated plaque means vascular surgeon is more interested and they want to go in faster, right? So all those have to be documented. Ulcerated plaque is very important to document as much as saying severe stenosis, meaning over than 70% asset. So picture, this is an older patient, it had an ulcerated plaque. And this I wanted to run by because this is something that people think they understand, but I get questions occasionally from even vascular surgeons, so I'm addressing it again. So ICA stenosis, there are 2 important trials. So we follow the NASA trial, which is a North American carotid endarterectomy symptomatic trial, right? In that trial, they look at, I just put in an image here so you can look at what we are measuring. So there are 3 measurements that is given in my picture. One is A, which is the narrowmost portion, which is of the ICA bulb, which is the pathology there. The next one is B, which is the distal normal appearing vessel in the ICA. And then C would be the expected dimension of the bulb. You can actually see the bulb, right? Because you're going to have fat around it. So you can actually see potentially where all there has been plaque or thrombus. So when you measure it by NASIT, it's going to be the distal normal minus the narrowed part by the distal normal into 100. Whereas in the European trial, they actually looked at only C minus A, C being the full potential bulb space minus the narrowed space by the potential bulb. So when I'm looking at the picture or anytime real time, it will look really, really bad because our eye automatically picks what the European trial mentioned actually, because you can see the potential space and it's really narrow, so it looks very severe. But then when I'm trying to measure distally, my NASAT measurement is not so bad. So we try to do in multiple planes in our 3D. It's not absolute, but relatively you can measure it. So we do it, and sometimes we even give a mean, but still the measurement doesn't look bad. And I do get calls from vascular surgeons. But when you look at it, this is what happens. Look at the percentages under NASAT. It's like 30% stenosis in NASAT measured as much as 65% on ECST trial. So this is the discrepancy. This is what our eye sees, and sometimes the radiologist gives a measurement and we don't agree. There's nothing wrong about calling and checking because it is a difference between doing surgery or not. But this is something to be aware of, okay? So always remember, though the eye looks, what to the eye looks so bad, there can be lesser percentage per NASAT. For NASAT, the percentage, which is critical, is 70%, whereas by the European trial, it's 80%. Do I report European trial? Not really. But in both cases, it's supposed to be technically symptomatic. We just report only the NASAT. So in this case, these are ant minis. I'm not sure how much you would have seen, but you see a corkscrew appearance. It's like a corkscrew, right? That's my internal carotid artery. Patient is tilted only because the way I had made the oblique. It's a sagittal oblique reconstruction I did, so you can see a longer length of the ICA where the arrow mark is. This is just burn it in your head. It's fibromuscular dysplasia. It's a very typical appearance. It does occur in the carotids, so it's a very well-known location for it. FMD. And this is something that we do. We put in stents and you guys would say, check patency. Very fair enough question. Sometimes because of the artifacts you cannot see, but the real way that we want to see is this one. So you can see a nice stent, and then you can see contrast flowing through it. Beautiful. And the person had done a fantastic job. It's like the stent is perfectly placed with almost near normal flow through it. That was a patent ICA stent. So this is a quick question. Anybody wants to take it? I did put it as a poll, but I'm not sure how it's going to go in terms of time. If anyone is willing to take it, we can do that also. We are in the vascular section. In your boards, if they show you something like a CTA, do look at the vessels because they're not going to trick you.
Sure, Dr. Ram. Are you just looking for like anything abnormal on this?
Yes. First, is it normal or abnormal?
I mean, I see some atherosclerotic plaque in the verts, right at the sulcus arteriosus, and then on the left ICA, I'm questioning whether there's a dissection. It's kind of hard with just one image. Oh, okay, I see a pseudoaneurysm. Sorry, I was looking at the axial. On the sagittal, I see a pseudoaneurysm in the cervical ICA at the level C1.
Good. When they show a picture, they're showing you the best picture they have. You have to trust that. Okay? If you cannot see, it means you cannot see, and it's probably there. So yes. The word question, yeah, it can be a plaque, but on the right side, it can also be part of the bone. So that part I would give. So it's a pseudoaneurysm. On the axials, can you guys see this little nice blob of the thing immediately lateral to the right lateral to the lateral mass of C1? It's the same thing. It's hard sometimes to pick. When I'm seeing a CTA, I'm just running through one vessel at a time. So it's going at a particular caliber and suddenly it bulges out and then it catches my attention, right? But however, when you do see all these reconstructions, I don't need to take that much time. It's like very obvious. So it is a pseudoaneurysm, and it is of a short segment, and usually they are associated with dissections. So this is what you would see if you see fractures, the question that you had asked. Put a bunch of stuff, but we are going to skip this. It was related to whatever we had seen. Okay, so quickly I want to touch base on CTV. CT venogram of the dural sinuses, we have a few pathology. Anatomy, I just wanted to do a quick one. So you have the superior sagittal sinus. Immediately below it, you have the nice inferior sagittal sinus. Both will connect at the straight sinus. But then you have these smaller veins. And then from the straight sinus, of course, you have the two transverse sinuses, two sigmoid sinuses, and the jugular vein. Now, that much we all remember. What we also can remember, add to it, the fund of knowledge, is the vein, the cortical veins. There are two big cortical veins that would help sometimes to remember. It's not common, but you can see these pathology. So the larger one at the top from the superior sagittal sinus is the vein of Trollard, and the larger one from the transverse sinus is the vein of Lebet. And then you have the deep cerebral veins, which would be the thalamus striate and the anteroseptal veins join and form the internal cerebral veins. And the internal cerebral veins, along with the basal vein of Rosenthal, will end up as a vein of Galen. In children, you find the vein of Galen aneurysm. So it's important to know this anatomy. With that in background, so when you order for a CT venogram, this is what happens. We give contrast. Image A shows a CTA, so you can see all the arteries well. And then slowly, as you keep moving towards the right, like towards D, now it's a mix of artery and vein. It's all contaminated, so that's why timing is important. Depending on where you catch is what we see. But by the time I come to image, say F, or even better G, I can predominantly see the major dural sinuses, and this picture correlates with the previous picture that we saw. With this as a background, we're going to move into this image. Is there anything wrong with this image? Of course, it has to be, right, because I'm showing it. And I'm looking at it, I'm thinking, is it a soft tissue or a bone image? Algorithm is the way we acquire, but once we acquire in whichever mode, we can always change it by windowing and leveling. This is acquired in a bone algorithm because it's so sharp. The bones are really nice, and because the idea was to see the bones. And there you see on the left side, fracture of the left, occipital bone, and you can even see towards the skull base going towards the anterocondylar canal. Now, if you go and then do a CTA, because I know next to this region is where I have my transverse sinus, I wanted to see if the transverse sinus is fine. So we get a CTV, right? In the CTV, I see the fracture. Next to the fracture, what's going on? I tell an answer and I go, everybody can see it. But when I ask someone to explain it to me, that's when you guys start wondering.
You don't see the left transverse sinus, and you'd be worried about a transverse sinus clot with the fracture there. It'd either be like a thrombosis or some epidural hematoma that's just compressing the sinus. Although I don't see any epidural on the CT tissue window.
Isn't that interesting? So if I would have seen on my CT head, my common sense would say, if there's a fracture, yeah, sure, I'm worried about the sinus, but if the sinus was injured, I'm going to be seeing something. But technically, in this study, easily you'll walk by this because there's just nothing seen. That is the pathology. So you can see part of the sinus on the right side, but if you cannot see the left, symmetrical portions that you can see. You cannot see the left transverse, nor the left sigmoid sinus, nor the left internal jugular vein is enhancing. So all of that is gone. This is considered an emergency because dural sinuses, when they get injured, they can really bleed heavily and cause intracranial hypertension and loss of blood and all that stuff. So watch it for those. It was one of the rare cases. I think it's a good case to even write up. CT perfusion. A quick run through CT perfusion. So cerebral blood flow is equal to cerebral blood volume by mean transit time. That is the basics for acquiring all this. So we are going to be looking at the blood flow, the blood volume, and the mean transit time, those three parameters. When you look at the normal perfusion parameters between the gray matter and the white matter, of the three, you see that the cerebral blood flow and volume is almost twice higher in the gray matter when compared to the white matter. But in the mean transit time, it's almost the same, right? So when you're looking at perfusion images, first of all, in your head, you have to know, okay, when I'm looking at CBV and CBF, I have to give this allowance for this difference. And after that, if anything is a defect, I need to pick it up. That must be in the back of the head. So sometimes it's easy for me to just look at mean transit time because there everything is almost equal. So anything that's abnormal, I don't have to give this segmentation between gray and white matter. So mean transit time is easy for me to perceive. Also, instead of looking at individual CBF and CBV, we do create just the time-based perfusion, the whole picture, right? Quickly, it shows whether something is abnormal or not just by visual detection. So it also helps. Quantitating it, there are lots of relativity to it. So the absolute measurements, I believe, have clinical errors, meaning errors that we will use which will affect clinically. So we'll have to be careful about that. Here, sometimes we report it because based on how I get those numbers, where I put my ROIs and stuff, those numbers get tweaked a little bit differently. So we do say, yes, there's a perfusion abnormality, or no, there is not. And we do talk about the penumbra because that is the key for the management. So they do talk about mean transit time, time to peak, and time to max, and those kind of differences. In the big picture, we do use mean transit time because it looks at a microvascular level, whereas all the other parameters, predominantly it tells about when the contrast is given and how much time it takes to get to the maximal tissue concentration. And if you look at it, contrast can also go through other macrovascular pathways, and anything abnormal in that is going to affect this number. So mean transit time overall is what we predominantly use. So if they are in the boards, if they say, of these, which one do you use, we favor mean transit time. Okay, so two things that we look at in CT perfusion is it an infarct? Is that a penumbra? So when you look at an infarct, the core has already infarcted. So whether you treat or not, nothing is going to be salvaged. In a penumbra, there is tissue to be salvaged, and we need to find that. How do you tell it? So the difference is, in an infarct, everything is decreased. It's all dead. So mean transit time is down, CBF is down, the volume is down. But when you look at penumbra, the mean transit time and the blood flow will be decreased, but at that early stage, the blood volume is trying to be retained. It's either normal or sometimes because of some cross-filling, whatever. There is even increase in volume in that region. So the quickest way to check, if any, would be cerebral blood volume will be the main factor, which will tell the difference between infarct and penumbra. So when you look at this is an infarct. The mean transit time, if you look at on the very left-hand side, it gives a sliding scale. So the lowest one is going to be blue, which means it's really low. And the highest one for all these images, it's going to be in red. So whatever is red, you know, is going to be high. And in mean transit time, you can see most of the left cerebral hemisphere is looking high. Correspondingly, if you look at the cerebral blood flow, it's blue in color, and you can know that blue, you know, these colors can be changed. So always look at your scale. You know, just blue, you don't have to go blue and blindly. So you can look at the scale, okay, at the lower part, it's blue, so that's blue. You can make it into a gray-white scale too. So blood flow is obviously decreased. Blood volume is also decreased. So this is a perfect picture where you know it's dead. You know, it's a full infarct. But in a penumbra, when you look at the mean transit time, see there are areas where the flow is the mean transit time is increased. Whereas when you look at the corresponding area on the blood flow, compare it to the other side. That's the only way to tell, because all these subtle things it's hard to perceive. So where you see mixed flow on the right side here, it's pretty much blue. So you know blood flow has decreased. Whereas when you come to blood volume, it's hard to tell. You can still see some amount of flow in the sulci, but there's not really a darker dip in blood volume. Sometimes these are very subtle, it's hard to tell. But definitely you can tell that it's not worse. So that was CT venogram. Now, MRI, this is just supposed to be basics, but you guys upgraded it into something that's more complicated, but I'm glad to help because as clinicians, I wanted it to be productive for you all. However, coming to MRI, when you guys say, I want this study, this is why the radiologist says, I'm not sure. I don't want to, all these reasons, because we have to follow these safety precautions. As a clinician, you just want it done because you are trying to protect and save somebody's life. We want to save their life in a different way. I know so many times you guys hate when we say no, but this is why. There is a web page. If anybody wants to look up something or talk to the technologists because they missed something, this is the page to go to. It's mrisafety.com. It was started by Sherlock. There are 3 gradations that we have. You know, if it's safe, no problem, put it in. If it's conditional, if you put something did surgery and there is an extra metallic something inside, it takes a little while for it to get embedded into the body. So up to 6 weeks or so, we don't touch the patient. Sometimes, like aneurysm coils and stuff, usually it doesn't get ripped out. So yes, in terms of emergency, do we do it? We do it. But a lot of times when you put metal into the body, like a fixation of certain kinds of things, it comes in a conditional, which means for 6 weeks, leave the patient alone. The last thing you want on top of everything is the whole thing ripped off at the 3rd-degree burn or something like that. Unsafe, don't touch it. If they say don't touch it and we touch it, there is no excuse. These are the sequences. Given the time, I'm just going to talk about it. People look at CSF first. So if it's dark, we think T1. If it's bright, it's T2. Okay, I think everybody's clear with that. But then the next level of looking at it is, look at the gray-white junction. In a T1, your gray matter, which is the outside the cortex, it's gray in color. And the white matter is a little bit brighter. Look at T2, on the contrary, the cortex will look a little brighter, whereas the gray matter will look a little darker. It's important to know that because when you come to this next sequence, it's the flare, which is the inversion recovery sequence. Now you can have a T1 or a T2 flare. Predominantly it's T2 flare. How can I tell the difference? Remember we talked, the gray matter looks a little brighter, whereas the white matter is going to look a little darker. So then I know it's T2 based. So though my CSF is going to be dark, I know it's a T2 flare. So remember to see that. People don't have to tell you what sequence it is. You can just pick it up. And then to my right, you have this is SWI sequence, or the susceptibility weighted sequence, or you can call it a gradient sequence. Depending on if it's Philips or GE or Siemens, they come up with different names. It's the same thing the way we look at it, but the names will change sometimes. So be aware of that. The gradient sequence, usually there's a gradient between the brain matter and the air, and it causes some artifact. And certain times, the most important reason for this is the blooming artifact, which you can see with calcification and with hemorrhage, right? This is the sequence neurologists love. If nothing, in that 30 seconds that you have to say yes stroke, no stroke, you look at these two sequences. So the image on my left is the DWI sequence. From it, I derive the ADC. ADC is not something that I go and scan the patient in, unlike the other sequences. Each of them is obtained at a separate time. That's why it takes that long, whereas CT is just one shot. But for ADC, you get from your diffusion weighted sequence, and they go parallel with each other. We read it together. And this is, what sequence is this? Can someone tell me? It is a T1 weighted sequence, right? CSF is dark, but the part is I'm also seeing contrast enhancement. So it's going to be a post-contrast T1. This particular whole patient was just a normal brain, okay? So the protocols, how do you order protocols? Now, some of the protocols we have are for the MRI brain, and then you have cranial nerves like the 7th, 8th nerve, IACs, and then you have the trigeminal nerve. You can have skull base done. Then, of course, the cell and the pituitary, it's a separate protocol by itself. Pineal gland, the orbit, then we have MR of the face for cancer, MR of the neck. So there are only so many that we do. If there's anything that you guys give specific history, we can always tailor to it. A lot of times, unlike CT, on MR, it's always with and without contrast. On a CT, it's radiation is associated with it, so we usually don't do both. If I want to check, say, sinuses, and it's not infection, all I need is just a without contrast for like sinusitis. But if I'm thinking abscess, then I want the CT sinus with contrast only, because I'm trying to cut down on the radiation of the patient. But in MRI, as a rule, a lot of times we get with and without contrast. And contrast helps easily differentiate between infection, tumor, vascular lesions, and post-hoc cases. This patient on a T2 has hyperintense. Remember, for CT it's dense, whereas for MR it's intense. So hyperintense signal is there in your caudate, putamen, in thalami. And also it's very hard to perceive on T2 about the cortex, but when I look at the DWI and the ADC sequences correspondingly. It's increased in DWI, it's decreased in ADC, so that tells me it is having restricted diffusion. So for restricted diffusion, increase DWI, decrease ADC. If it's not restricted, then DWI sometimes can be increased, but if ADC is not decreased, it's just T2 shine through, leave it, walk away. So in a patient with so much global restricted diffusion, the answer is going to be anoxic ischemic injury. Just wanted to put some anatomy, no time for it. So CT, there's a large isodense mass in the region of the sella suprasellar region, right? So now I want to get in. This is without contrast, so I can actually see things even without contrast on a CT. And then I'm getting an MRI. So I put these because this is how we see. These are some of the parameters that we look into: the thickness, what are my various TE, TR numbers, but we're not going to go over it. It's a little bit of physics, which we'll skip for now. Coming to the pathology. In the sella, you see this large mass, which is going to the suprasellar region. So it is impinging on the suprasellar structures like the optic chiasm, prechiasmatic optic nerves, and hypothalamus. You can see the mammillary body well here. But this large mass predominantly is going to be a pituitary macroadenoma. There is a differential, but common things being common. In the coronal plane, it's the same thing. You can actually see the optic nerve being stretched at this point. This is then the left internal auditory canal. The arrow points to a mass. It's a cone-shaped mass which comes from, you can see the enhancement. Enhancement is coming from the IAC into the CP angle. So when you see something like this, think of vestibular schwannoma. The reason I put this is because of this difference in sequence, which can tell what kind of cellular structure is in there. So the image on my right is a T1 weighted sequence where fat is bright, CSF is dark, and this mass has same intensity as fat. And T2, again, fat is bright, CSF is bright, and you can see the mass, which is bright on T2. So I'm thinking, well, bright on T1, bright on T2 can be a few things, including like protein and various stages of hemorrhage. However, fat can do it. How do I pin the diagnosis? This is a fat sat image on my left-hand side. When the fat is satted out, then this mass is also satted out. So I know it's going to be a lipoma. So there are times when you can slam dunk. You can do it on CT too. This is a large mass, and it has peripheral thick heterogeneous enhancement. You can see the midline shift. You can see subfalcine herniation. Probably is beginning to trap the left lateral ventricle. When you see something which is so big and it has surrounding large vasogenic edema, you have to think tumor. In the adults, most common is metastasis, but by the time you see things like this, you have to put in a high-grade glioma like GBM. This is another nice case of a CT showing a subtle lesion in the right inferior parietal region closer to the cortex. It's very hard to really characterize it, but when you get an MRI, you do see, based on the DWI and the ADC, the restricted diffusion, and you see the lesions beginning to enhance. So GBM can have restricted diffusion, sure. However, when you start seeing all this meningeal enhancement and there are multiple skipped lesions, one of the important things that you need to wonder about is infection. So this ended up being an abscess. They do call this dual rim sign. Okay, so the inner on the T2 sequence on the left-hand image, if you look at it, there is this bright, meaning hyper-intense line followed by a hypo-intense line. So when you look at that, consider an abscess, particularly when you have restricted diffusion. This is for the seizures. I know we have a different conference for seizures. So when you look at the hippocampal formation, it's always an eye test. So if you see atrophy, if you see increased T2 signal, if you see less of the three lobations of the hippocampus, consider MTS, mesial temporal sclerosis. This is in the axial image. Just look at it. Try to tell, make sure that your eye is able to see the difference in the gray matter, white matter difference, and the symmetry. And when you find this, they go in, they do ablation. This was a study which they had ablated. So at this point, I'm going to stop. Do you guys have any questions for me?
No questions, Dr. Ram, but thanks for the presentation. That was really nice.
Thank you.
Um, if you have any questions, please contact me in the chat. If you can put something that helped you, that will be great for me to understand. Sometimes I have a presentation to give and I can continue talking, but particularly in a video conferencing, I do like to see where you guys want to know, because a lot of you guys are like neurologists, neurosurgeons who already know a lot of this. So I want to make it more useful for you guys, because that is my audience I'm targeting. So let me know in future, then I can tailor how I give these conferences to you guys. But it was a pleasure meeting you all virtually. Thank you so much. Do you guys have any questions?
Thank you.
Yeah.
Thank
you,
you so
Dr.
much.
Ramo.
Yes, ma'am. Thank you.
You're welcome. I was just getting to MS and the McDonald criteria and all that stuff, but I think that would be not part of the neuroimaging basics. It's more advanced.
Yes, we very much enjoyed it, and we'd love to invite you back soon. Thank you.
Thank you, Dr. Ramo. And I know you guys are busy, so have a wonderful day. I will be here for the next 2 minutes. I'm going to check the chat. If there's anything that you guys wanted to talk to me about, please let me know.